All right, good morning, ladies and gentlemen. Thank you for joining me today. Today, I will be presenting my proposal for my research on aggression in inpatient care units. Before we get started, let me go ahead and give you some background about my program. I work at Alpine Special Treatment Center Incorporated, which is a long-term residential treatment center for individuals with SMI, or severe mental illness. We primarily deal with psychosis, so this means schizoaffective disorder, bipolar disorder with psychotic features, and schizophrenia. This is a private organization with a income of about $16 million with about 128 clients. So it is one of the more expensive programs available. However, there are actually only two available to Southern California. The clientele is made up of about 35% white, 35% Hispanic, 15% African American, 10% Asian, 5% other. This is actually a very representative population of the greater population of Southern California. Age ranges are again equally diverse, the youngest being about 20 years old, the oldest being 73, with a median age of 36. Due to the nature of the program, our beds, we allow 50% women, 50% men, and again, this is due to the bed's availability. Income is also represented in our clientele. We have clients from that are there with Medi-Cal, Medicaid, as well as private pay insurance, as well as out-of-pocket pay. So the income range is also representative of Southern California. I'm going to talk a little bit about the policy I will be reviewing. And this is a policy of Alpine Special Treatment Center around aggression. Multiple studies have come out citing that individuals with severe mental illness do have a tendency to be more aggressive than the greater population. This is one of the contributing factors, according to NAMI, of the increased incarceration of individuals with mental illness. This can be acting to stimuli or interacting with the environment around them. Aggression does include property destruction. This aggression follows these clients into whichever facility they are housed in. So if in the case of incarceration, in the jail, in the case of Alpine Special Treatment Center, we see the same rates of aggressive incidents. The approach that Alpine Special Treatment has taken for this is called CPI. This is a training course to deal with aggression and violence, and is probably the, I'll say, industry standard at this time. There are only two studies studying its effectiveness. Both are from the 1990s, and they have relatively small subject pools. However, they have been shown, those two studies point to an 83% reduction of aggression in healthcare facilities, and again, it is the industry standard as of now. So what exactly am I going to be researching of this policy? My research question is pretty straightforward. Is CPI training and Alpine Special Treatment Center's policy on aggression the most effective policy out there? How effective is it at reducing incidents of aggression? And if needed, what alternative practices could be introduced to reduce those instances of aggression? And why is this important? Well, for the clinic, it's important to, of course, have best practice. And aggression on the floor is both dangerous for staff and for other clients, and it's not conducive to treatment. For the field in general, there is not a lot of cohesive treatment from clinic to clinic. A lot of it is based on each individual clinic making decisions that they feel works best for them. Through the use of this research, I hope to be able to at least begin to create a standard practice for residential treatment centers treating SMI, to kind of better, I'll say, balance the form of treatment available. Before we move on to the actual research designs, this is my logic model. Pretty straightforward. And go ahead and take a moment to look, pause the video if you'd like, and we will move forward. So the available research is fairly robust, as a matter of fact. This is a very important question that a lot of people do try to look at. Majority of, instead of talking about each individual study, their shortcomings, and what their findings are, I'm just going to give a general synopsis of all of them because they all pretty much came to the same conclusion. Majority of these are literature reviews and meta-analyses. So they synthesized multiple research papers, and this is a summary of those summaries. Essentially, everything has found that research is still needed despite the robust pool of research, and this is mainly due to each clinic having their own personal practice. Subject pools are generally very small. Practices are generally ill-defined and are extremely dependent on the individual purporting the policy, and there's minimal, again, cohesive agreement on what best practice is for this population. There have been a couple of positive ones, primarily the bottom papers, Steinhardt, Elsil, Gosser, Toshik, and Ullman and Schmid looked at changing organizational structure and its effect on aggression reduction. That was shown to be a influential change for instances of aggression. There's also some alternative alternative practices to CPI that are mainly employed by jails to, again, deal with individuals with SMI that are incarcerated. These alternative techniques are going to be the primary basis of my research. How well do these programs uphold outside of a jail setting, and if they can be implemented in a residential treatment center? The research stated by Hermanstein and Manjurian, the third down, supports this hypothesis that these techniques are not only more effective, but are able to be implemented in that sort of facility. So moving on to my methodology of my research, and this is going to be broken up into two stages. The first is a qualitative survey design, and this is going to be a staff survey that I'm going to use to measure kind of the staff's feeling of safety and client safety while working. This is based off of the SCO assessment, the Patient Safety Climate in Healthcare Organizations. This is a 58 item survey that has been validated and is available for open use. It was developed in 2001 and again has been proved to be a valid measure of safety climates in healthcare organizations. This will be offered to staff on a free range basis. Whoever can apply whoever can reply to the survey has the opportunity to do so. I am in the process of offering some sort of compensation, such as a gift card to a local restaurant for lunch. That will be offered randomly by the respondents to the respondents. There are about 60 staff members available, and while a small pool, if I am able to accomplish at least 70% response, that will give me enough to generate a significant image of what the safety climate is at Alpine Special Treatment Center. The second portion of the study is going to be my actual research, and this is testing the alternative techniques described by Hermstay and Managerian. This will involve a pre-observational analysis of aggressive incidents reported in a quarter, and then the training and implementation of these new techniques, and then a post-analysis of reported incidents. It is my hypothesis that with the implementation of these new techniques, those incidences will diminish, and I hope to see a significant reduction of incidents reported. This will take place over a 3-month period, again, 1 quarter, so we'll be comparing a quarter's reports to another quarter's reports, giving me a picture of 6 months. So what are the barriers and limitations to this research? And unfortunately, there are a few. The first being staff compliance with the surveys. Staff is already worked fairly thin, and there are complaints of not having enough time to do duties required for the running of the facility. For this reason, it would be difficult to convince individuals to take the time to sit down to complete a 58-item questionnaire. That is the purpose of the gift card incentive, and will play a major role in my ability to collect an accurate picture of the program. Another barrier is time frame of study. Comparing only 1 quarter to another quarter is not the best case scenario for an accurate picture of a residential treatment. Many clients are in treatment for an entire year. There are definite seasonal inputs to moments of aggression. They tend to increase around the Christmas time in the winter when individuals are not able to be outside, and that is going to fall on my 3 months to test this new technique. For this reason, it won't be a complete accurate picture, but it will be a positive first step. Second one is cause and effect. There are multiple reasons for aggressive incidents. I mentioned the seasons. We could get a particularly aggressive client during that time admitted and have one of our safer clients discharge over that time. This is absolutely a causality research question, determining if the new implementation of the techniques affect change on incidents reported. Further research will be needed post this study to confirm any findings this research may turn up. The last one is organizational bias, and this one is primarily around the idea that Alpine Special Treatment Center does pay for the right to use CPI in the on the floor, and it is a significant investment on their part. For this reason, I anticipate some pushback in implementing new techniques, especially techniques that would require a full retraining of staff. As a for-profit organization, cost effectiveness is extremely important and should be accounted for in this study. These are the works cited for the information presented. Thank you very much, everyone, and if you have any questions, please direct them to myself at ryan.barletta@du.edu. Thank you very much.